Now, in the fifth and final section of our lecture, now we will discuss the treatment options for stage 3 and 4 of hepatocellular carcinoma. And in this, we use the drug inhibitors for the treatment of stage 3 and 4. Then the novel medical treatment strategies are used, and then evaluation of some non-surgical responses for stage 3 and 4 of the hepatocellular carcinoma. So the treatment of stage 3 and 4, we have the systemic chemotherapy. These are not even 25% response rate. So we know that stage 3 and 4 is now the advanced stage of the carcinoma, and the prognosis is very poor. So with the systemic chemotherapy in this stages, the response rate is not even 25%. Single or combination of agents are used. Then we have another kinase inhibitors, in which we have oral multi-kinase inhibitor sorafenib. Targets RAF mitogenic and VEGFR is used. So targets of this kinase inhibitor is RAF mitogenic and vascular endothelial GFR. Associated toxicities, usually there is fatigue and hypertension associated with the kinase inhibitor. New therapies used are bevacizumab and erlotinib. Then we have external beam and conformal radiation, and then nitro-yttrium therapy. So these are some treatment options for class 3 or stage 3 and 4. Systemic chemotherapy is not very effective. Kinase inhibitors are used. They have their own side effects and toxicities. And then some new therapies are also tried for the treatment of stage 3 and 4 hepatocellular carcinoma. Trials with vitamin K is also done. The drug inhibitors which are used, new targeted agents, and their targets in current clinical trials. So the targets and different drug inhibitors which are used for hepatocellular carcinoma, and what's the targets of these inhibitors, let's go over them. EGF receptors, and the inhibitors used are erlotinib and gefitinib and cefoximab, panitumumab. So all these are the different inhibitors used for the treatment, and they target the EGF receptor. Then the CMET is the target, and again the drugs used or the inhibitors used, we have tivantinib, EMD 1204831, and then also cabozantinib. This is the inhibitors, and that's the target. Then the target is VEGF receptor, and the drugs or inhibitors are bevacizumab, regorafenib, brivanib, sidaranib, and sunitinib. So all these are the inhibitors. FGF1 receptor, again AEW54, R1507, lectinib, and brivanib. So these are the inhibitors, and the target cells we are going over. And then we have trail R1, which is pro-apoptosis, mepatumab. This is the inhibitor used. PDFG receptor is the target, sorafenib, and dovitinib and lenifenib. IGF-1 receptor is IMCA12, B11B022, and 622 Then we have ubiquitin proteasome, and this is the inhibitor used is bortezomib. These are different drug inhibitors used, and the target of these are different receptors which are targeted by these inhibitors, and they inhibit these receptors. Novel medical treatment strategies for stage 3 and 4. We have EGF receptor antagonist, again, which are erlotinib, gefitinib, lapatinib, cefoximab, and brivanib. So these are different drugs used according to novel medical strategies. Multi-kinase antagonists, which are sunitinib and sorafenib. VEGF antagonist bevacizumab. VEGFR antagonist ABT869. mTOR antagonist, then we have proteasome inhibitors, vitamin K, 1311 ethiodol, 1311 ferritin, and then we have 90 yttrium microspheres. Different treatment strategies can be tried. Three-dimensional conformal radiation, proton beam, high-dose radiotherapy, gamma knife, cyber knife. Then we have new targets, which are inhibitors of cyclin depressant kinases, CDK, cyclin dependent kinases, which is trail induction caspases and stem cells. So different treatment options are tried, but as we know that the stage 3 and 4 is the stage where the prognosis is poor, because it's already now there is vascular invasion, distant metastasis, more nodal involvement, but the different treatment options can be tried to benefit the patients. Regional chemotherapy. Doxorubicin and cisplatin used, regional administration, embolizing agents used like ethiodol gel foam, regional hepatic arterial chemotherapy, fever, abdominal pain, anorexia, common effects. Degradable starch microspheres if embolization, and drug-eluting beads using doxorubicin. So these are different regional chemotherapeutic options tried for the treatment. Evaluation of non-surgical responses. Chemotherapy lead to the shrinkage of tumor size. So if the non-surgical options are used, what are the evaluations of those responses? For chemotherapy, it caused shrinkage of the tumor size, regression of the size of the tumor, poor survival in tumors, ovarian cancer. Sorafenib, hepatocellular carcinoma assessment, randomized protocol, SHARP. Response evaluation criteria in solid tumor. Semi-quantitation of tumor vascularity, diffusion weighted MRI imaging, plasma alpha-fetoprotein response, and tissue-specific imaging agents. These are all the evaluations of the non-surgical responses of the patient with hepatocellular carcinoma. This was all about the topic hepatocellular carcinoma, in which we tried to cover up mostly all the etiologies, clinical features, diagnosis, investigations, and in detail we talked about the treatment options available for stage 1, 2, and then stage 3 and 4 hepatocellular carcinoma. Thank you for watching sqadia.com.